Welcome to Conversations with Black Doctors, brought to you by Austin Black Physician Association, also known as ABPA. My name is Dr. Jeff Hutchinson, and I'm an adolescent physician in Austin, Texas. I'll be the moderator for this panel. The mission of the Austin Black Physician Association is to improve health disparities within our community and to inspire and nurture the next generation of Black doctors. If you're interested in learning more about or collaborating with ABPA, please visit austinbpa.com to connect with us. That's austinbpa.com. The purpose of this conversation is to bring health information to our community from trusted voices in the Austin area. We want everyone in our community to have the knowledge to care for themselves in the best way possible. Please share this webinar widely. Today's topic is disparities in diagnosis and treatment of high blood pressure. The topic is important to the ABPA and the Black community for three reasons. First, hypertension is seen more frequently in African Americans. Second, high blood pressure can be controlled with lifestyle changes and medication. And third, having high blood pressure makes other illnesses like COVID-19 more dangerous. Joining us today are two Austin area Black physicians who are experts on this topic. Dr. Tannen Carroll and Dr. Desmar Wilkes, thank you both for joining us today. Would you please introduce yourself to our guests?
So I'll go first. My name's Tannen Carroll, originally from Houston, Texas, and actually went to the University of Texas undergrad and then trained on the East Coast and the West Coast, and I've actually been a cardiologist and an interventional cardiologist here in the Austin area for the last 7 years. So my areas of interest are specifically heart valve disease, for which I helped start the valve clinic at Seton. Also, my other interests are coronary artery disease, stroke, and high blood pressure. As you can imagine, as a cardiologist, I encounter high blood pressure every day. And to be honest, I think it's one of the main controllable things that we can do as a community to decrease our disease burden, particularly in cardiovascular disease, which is the #1 killer. And so I'm glad to be here and to share my insights on how how we can tackle hypertension in the Black community.
Great.
Hi, my name is Dr. Desmar Wilkes. I'm a family practitioner in Bastrop, Texas, which is just outside the fair city of Austin. I've been in practice in Bastrop since 1994. I also do a sleep lab. I have a sleep lab in my office, and we are involved in a lifestyle practice of medicine, particularly looking at the impact of lifestyle choices and changes on chronic disease and illness. And thank you for having me be part of this conversation.
Great, thank you both. So let me start with a common scenario that most of us can relate to. Let's say that my dad has high blood pressure, hypertension, and he's had it for several years. He finally admits to me that he stopped taking his medicine because he feels fine. What can I say as a son or daughter to my parent about taking care of his high blood pressure? Dr. Carroll, would you start?
So, like you said, I think that's a very common scenario as physicians that we encounter. And I think one of the things that we can do as physicians most is take the time to spend and find out why our patients feel that way. So I think, the tough thing about medicine nowadays is that we don't have the time to spend with our patients to discuss their beliefs that they come in with, their understandings of the disease processes, to really tackle the barriers which keep them from taking their medicines in studying health disparities. I found that one of the things that's the most challenging is that I think one of the things that we can change is the health literacy. And so sometimes as Black physicians, taking the time to kind of sit down with our patients, kind of find out what those barriers they bring to the table, find out the reasons why they aren't and then meet them where they are when we find that they're not taking their medicines. Part of the approach that I take is I think there's twofold. One is to talk about the end results of high blood pressure. I think those are the things that people understand. So talking about stroke, talking about the heart attacks, heart failure, that is the most common cause for why people end up on end-stage renal disease. So I think talking about those end results and not where we are now is very important to motivate patients. The other thing that I think is very important is also to talk about the actual, I think the other thing that's important with this is to actually talk about other things outside of medicines that really help patients with hypertension. I think a lot of us as physicians, we come in and we give you a prescription and we say, this is how you take it. But as Dr. talked about, I think that if we talk to them about the things outside, so diet, exercise, sleep apnea, other things that have an impact on weight, all of those things that have an impact outside of medications, and give them goals to set outside for lifestyle changes, I think that also helps motivate them as well. So it's not just the medicine part, it's the education part. It's also talking about the other things outside of medicines that will help them tackle this disease.
Great, thinking of them as a whole person. Dr. Walks, what do you think?
I think that Dr. Carroll has covered a lot of the issues surrounding not taking medications. One thing that I've also noticed is that there's an interesting phenomenon in that some people don't understand that hypertension is not like a cold or, a UTI, a urinary tract infection. It's something that is a chronic illness, and it requires that you take the medication long term. And so I think when we give a prescription to somebody and they leave our office, having that conversation about, well, this is going to get your blood pressure down and you need to keep taking it to keep that blood pressure down is really important, because I've had people come in and say, well, it's interesting. They may not know what their medications are for, but they'll say, well, I had blood pressure problems, but now I'm fine because my blood pressure's fine. And they don't realize that on their list of medications, they're actually taking something for high blood pressure. And the other thing that I would add is that going back to what Dr. Carroll mentioned, it's really important to find out why they're not taking it. Sometimes it's because they've read that package insert and they've decided they're going to have all of those bad things that they've read on the package insert, so they're just not going to take it. And other times it's things like they can't afford their medication, or they got a note in the mail from their insurance company and it said this drug's not covered, and they don't realize that doesn't mean that the drug's bad for them. It's just that there's another option that they need to talk to their doctor about changing to. So the medicine has become so complex because there's so many hands in the pot. I think it's, as Dr. Carroll said, taking that time, just, a couple minutes just to kind of ferret out what the problem is really important. Great.
So thinking about the person as an individual is really important going from here. So that was a wonderful answer from both of you, focusing on the individual and what we can do for the individual. Now, let me broaden it a little bit and think about as a population. Now, we hear people say that Black people have more high blood pressure than others, and that's one of the reasons why we have more health problems. When you think about us as a group, what do you think makes us or make our outcomes different than other groups? And maybe Dr. Wilkes, if you want to start with that one.
Well, I think a lot of it stems from our populations not having access as readily to healthcare. And because there's lack of access, I think that folks, if once they get that health insurance card, if they decide that they're going to use it and go and see a doctor, they're hoping that they're going to get in, have a physical, be told everything is fine, and get some blood work, and then maybe they get to go next year. And so when you turn around that expectation by telling them that there's something wrong, oh, and by the way, you have high blood pressure, and oh, by the way, it's something you're going to have to deal with for an extended period of time, maybe that's going to be a lifelong issue for you, then you're impacting not only their expectation, but they're thinking about the long haul. So they're going to have to buy medication every month or every 3 months. There may be some requirement for blood tests to be done to monitor renal function or whatever. And so that conversation then becomes a little bit more difficult, because it already costs so much for them to have health insurance, and they just got it, and they were hoping that they were going to have that physical and they were going to be okay and not have to do something extra. So taking the time to really talk about that whole impact on them, I think is important. And as Dr. Carroll said when we were talking initially about this subject, really having a frank conversation about the fact that not only do they really need to pay attention to this, and maybe during that first conversation, we're going to be talking about lifestyle changes. If they really do the work for the lifestyle changes, they may not have to take medication, and explaining to them why, if they don't do something to get the blood pressure down, they could have a stroke, they could have a heart attack. Because it's the saddest thing for me is to see a 40 or 50-year-old Black person have a stroke. And then, all the things that happen as a result of that, rehab and maybe even nursing home admission.
Yeah.
Those types of losses of quality of life need to be talked about, so they understand that this is real, and it is important to cut the salt out, do the exercise, and lose the weight.
Right. Yeah, there are definitely things we can do for individuals. But also there may be population things that we can do. Dr. Carroll, what do you think about the fact that there's a difference among our outcomes with the Black people than with other people?
Yeah, I mean, I think you asked a very complex question that, they've done whole hours or studies or shows on the health disparities. So I think, to kind of talk about it in a short period of time wouldn't do it justice. But I think there's a couple of things that I thought about when this topic was brought up, and kind of what I see with my patients and why those disparities as a community exist. So I think first we have to talk about, there's a general distrust, and this goes back to access of the healthcare system. And mostly because I think it's that they don't have a lot of physicians who understand where they're coming from, who look like them, who come from their communities, who take the time to spend that. So I think there's no doubt that, as we had talked about when we were talking about individuals, they come with a set of barriers that really, that they already come with preconceived notions or distrust of the healthcare system from their own experiences. The other thing that I think is I'd mentioned this before, and this is one of the things that I think as a Black community we can work on, but I really think there's a huge gap in healthcare literacy. And what I mean by that is that, understanding the treatments, understanding the outcomes, being able, one of the things that I've noticed is that, now as healthcare has changed, we've got more demands on our time for compensation and spending time and seeing more patients. The time we actually have with our patients has become less and less. And the patients who have the highest healthcare literacy, the ones who come in, they know the questions to ask, they know what they get the most out of that 10 minutes that I have, that 15 minutes with them. Whereas if you come in and you haven't done the reading, or you don't understand the disease process, and you don't have that, And the interesting thing is this is played out in hypertension for sure, but diseases like heart failure, where knowing how much fluid to take in, your dietary salt, what those medications mean. So I think that, and another example of that is in asthma too. So for instance, with, and you probably know this more so, but in pediatric populations, kind of the things to avoid, the times when to go to hospital, all of those kind of things. So that health literacy is a big gap where I see in our community versus my other patients who come in and have been more and are more prepared for that. And then
That's great.
The other thing that I would say is that I do think that lifestyle plays some into this, and particularly when it comes out to diseases like hypertension. One of the things that a big public health service, and this came down, is cutting out dietary sodium and doing things to cut down dietary sodium. I think probably if as a community we made it a concerted effort to just cut sodium, it would probably be one of the biggest things we could do for actually high blood pressure in our communities. And then also talk about exercise and kind of, having the expendable time and the understanding of how important and what type of exercises are important to lower your cardiovascular risk and your high blood pressure. So, and then the last thing, and I just want to go back to what Dr. Wilkes has said, I think the access part plays in that what we see as physicians, and at least for me, is that when patients finally, and this kind of goes back to what you were saying about, they come in for their first visit and they're upset because now they have a long list of things. But what I found is a lot of people in our community present with end-stage disease. And kind of, they've had blood pressure for high blood pressure for 10 years, and now they come in with stage 3 kidney disease. Or the first time we see them, they already have that cardiomyopathy or they have the heart failure. And so I think that lack of access leads to us presenting with more advanced stages of diseases when we do present, which can be quite discouraging for our communities as well.
Absolutely.
Okay.
Thank you. Thank you both. So we hear negatives, but early on, you did mention that this is one of the illnesses that can be changed. There's a lot of hope for having better outcomes. Can you briefly share a story of successfully treating or successfully discovering, or just can we hear a little bit of good news at least from either of you? And maybe Dr. Wilkes, if you want to start with this.
Well, it's kind of what Carol just talked about is true. I tend to see people after the fact when they've had hypertension for quite some time, and I'm looking for the help of a cardiologist or a nephrologist. But one story that is a success story in a roundabout way is a 55-year-old Black gentleman who was admitted to the hospital and he had a stroke, and he was uninsured, and got through his admission. They gave him some TPA, and he had some residual weakness, so he couldn't move his right arm and leg very well. He actually was using a walker when I first saw him. He had had blood pressure issues all along, and he was one of those folks that didn't quite buy into taking the medication, and then had a time when he just couldn't afford it because he was uninsured. So, and no one had really talked to him about some resources that are available, like the $5 programs at some of our local pharmacies for getting meds and so on. So he was discharged. He came to my office for the first time, and he had a packet of discharge papers, and in that packet there was a promise that he was going to be able to go back for physical therapy at the local hospital where he had been treated, and he was still waiting. It was like 2 weeks later to hear about whether that was going to happen, but that wasn't in the offing because he didn't have insurance. And luckily, at that time, I had a gym at my office and a personal trainer, which made it affordable for him to come and actually get some physical therapy. And we had that conversation together about the $5 plans or $4, depending where you went, to get blood pressure medicines. And we looked over the list, and I found some comparable substitutions to what he'd been discharged home on. But the good news is that after about 6 weeks of doing the personal training, this man was able to walk and get his movement back and strength back and actually go back to work. And because he had more affordable choices for his medications, we also got his blood pressure under control. Kidney function improved, and he's now working and really understands the importance of blood pressure control. He stays on his medicine, he's checking his blood pressure. And to me, that was a real win, because we took this man who's got kids and family to support, and got him back into the workforce, and with a really good understanding of what blood pressure control means and how it can impact your life. So that was a great for me, and for him.
Yeah, that's wonderful.
Yeah.
Dr. Carroll, do you have any good stories?
Good stories. Okay. No, I think, it's funny, as physicians, a lot of times we are kind of conditioned by our bad experiences. But what I will tell you is that I do have lots of patients who have been very successful once we sit down and we talk about that. I think one of the patients that comes to mind now is actually, I had a patient who was a professional basketball player. He's an older gentleman, but was a professional basketball player about 20 years ago. And so he's someone who was healthy, worked out, traveled, did all the right things, and thought he was invincible. And then he came in with a heart attack. And so, part of that, after we got off the table and we placed the stents that he needed, was that discussion about, you too, even though you've done the right things, you've been an athlete, you done all those things catch up to you too. And you do have to worry about the important things like watching your blood pressure, watching your cholesterol, screening for diabetes, all of those other important things. And so now he's doing great. He's a year out from his stents. He's and we're doing, and he's very happy with everything and understands that it can happen to anybody, and is a big advocate for taking medications and following up with his physicians and being proactive instead of reactive to these medications.
Great, and that's a great segue to my next question. And for either of you, as a Black physician, do you think it makes a difference to your Black patients that you're also Black?
Yes, I do. Yeah.
Do you both agree with that? Like, have you seen that in action where your patients relate to you on a different level that you believe they relate to other physicians?
I think they feel a level of comfort in knowing that we have an experience that's a common experience to theirs. And especially if we take the time to listen to them and to talk about, well, yeah, maybe you shouldn't put the ham hocks in with the greens, 'cause a lot of salt, we love it and do that, so, and I think that, establishing rapport and some level of familiarity helps make that conversation be heard, because otherwise you could be speaking a lot of medicalese that falls on deaf ears, and you're not being effective. And if you're wanting to be effective at having good outcomes, you really have to establish a rapport so that they're hearing what you're saying and they're understanding that it comes from a place of caring. And so you get past a lot of barriers when you walk in and I look like you do. So.
Absolutely. What do Black people get wrong about high blood pressure? Like, what are some common myths and misconceptions that you all see in your practice?
Well, some of the myths that I think is that I don't think a lot of African Americans or Blacks understand the end stages of hypertension. So I think they see that, you know, there's strokes, there's heart attacks, there's end stage renal disease, but they don't understand the processes before that. The high blood pressure was what led to that. And so I think, you know, changing that mentality to a preventative mentality. And like you said, part of that is access. Part of that is distrust of the medical community in general. But I think if we could flip that and not seeing diseases as my mom had a stroke or my mom had a heart attack, but she had these risk factors that actually led to that. And I think, you know, that misconception is important. And then I think also is that, you know, I think a lot of people don't, and I think part of that misconception also goes back to there are lots of things that we can do to prevent those future things. So, you know, if you understand the risk factors before, you can do that. The other thing is that I think there does seem, and this goes back to the distrust, you know, medications and compliance, I think there are lots of barriers to that, but I think, you know, having that, how we have that conversation with our patients and the side effects and the experiences that their family members have had with different medications, it makes a big difference. And so talking about those misconceptions that they have, or that they don't need to take these medicines, or even more so that we only need to take medicines when we feel bad.
Yeah.
I think that's the common one. And I think that's also the tough thing about both diabetes and high blood pressure is that patients a lot of times feel well.
Mm-hmm.
Still out there doing their normal things, they're able to go to work, they're able to do all the things they want to do until they have an event. And so I think, you know, changing that paradigm is important to decreasing the disparities.
True. Can I ask you to both put yourselves in the patient's shoes and say you're a patient who's not fortunate enough to get such wonderful doctors as yourselves, but they're not sure that the doctor in front of them cares about them. What question can you give them to ask their doctor to help at least guide them in the direction of getting good care? Is there a question that they can ask or a statement they can say that can help the doctor who's taking care of them see them more as a patient that they care about?
Wow.
I ask easy questions.
Well, the one that always I think gets me is when somebody says, "Doc, I know you can't fix everything, but I just want to make it to see so and so graduate." You know, that one really kind of lets you know that they're there because they want help to improve their quality of life and their health at the same time. And I think there aren't too many doctors that are in this to be doctors that wouldn't look at that and say, "Hey, I need to buy into this and really do something to help this person."
Yeah.
Yeah, but and one of the things that I would say is just being real. You know, one of the things, you know, it's funny, and I think what makes a good physician is understanding that it's not the science of medicine, it's really the art of medicine.
Mm-hmm.
Patient comes with different challenges, different things that they have. And so I think, you know, probably it's a false question to say that there's one question in particular. But what I do say is being open to your physicians. You know, being able to feel comfortable, being able to ask real questions and talk about the way you feel at home when you have to take these medicines or the real barriers that you have. You know, for me, it's that interaction. It's that that exchange that really makes it more real for me. You know, I joke with, and this, maybe I shouldn't say this on this, but I joke with my my staff that, you know, if I remember you, because I have a lot of patients, then you're really probably pretty sick. But that, but what I mean by that is that there are lots of patients who come through, but there are patients that I remember who have individual stories or individual experiences, and those individual experiences, those individual stories, those are the things that make it real for me. And I think that really helps with the outcomes and me to help them as a team to get over their disease processes.
That's fantastic. So we're nearing the end of our conversation. And as we go, I'd like to ask if either of you have resources that you want to share with our audience who might have questions about high blood pressure, hypertension, either treatment, care. Where would you want them to look if they wanted to know more?
So I'll start. Particularly the American Heart Association has a campaign this year. Our campaign this year was specifically focused on hypertension. So if you go to the heart.org, I believe, or the AHA website, they actually have put in special community programs this year. And that was what our big fundraising drive was to raise awareness in the community for hypertension and to come up with resources for communities of need in hypertension. So I think it's an interesting, the website itself has lots of resources that are available to help with understanding that. And I think it's a good thing for you to visit if you have any questions.
Fantastic. Dr. Walks, do you have any last words or recommendations?
I just urge anybody who's watching this video who has hypertension to please take your medication and do all that you can to keep your blood pressure controlled so you can live a happy, healthy life and be well. Thank you.
Great. Thank you so much, Dr. Walks and Dr. Carroll. We're grateful for your time and expertise. Thank you to our audience for listening wherever you are. ABPA wants to continue to further its mission to improve health disparities within our community and to inspire and nurture the next generation of Black doctors. Please visit our website, austinbpa.com. If you or your organization would like to ask questions, you may also send an email to info@austinbpa.com. Thank you again so much and have a wonderful, wonderful day.
Bye. Thanks.